It's just funny. He went like this. He looked at me though. He goes.
And you know what? That was the last person you should have done that.
I know. I'm like, did you forget who I am, buddy? He's cute though.
Hello, Dawn.
How are you?
I think I just saw you.
I did do this team.
How did you get home?
Well, he has a tablet now, so he skipped the last part, but he was stuck there. I was gonna text John. I told you that. So bad. Am I like this? No. Okay, good. Hi. How are you guys?
Joey ran into here, so
I didn't send anything out. I always send a text or a Facebook post or an email, and I do nothing. I know, you guys slipped in. How are you?
so glad you guys came.
Oh my God. Where is he now? And Jamie? Well, that's good. I was like, stop. Where's Jay at?
So well done.
Sure, we'll go with that. Yeah.
And Jenna, I think you're traveling the world.
Oh, good. Did you get to hear me yesterday? Yes. A couple weeks. September 9th. So I sent the link out. So hopefully, for whatever reason, your emails always. Who is it?
Too much. That was stretching. Always weird. Do something. Yes. Don't stretch.
Oh, you were kids.
Pain is an indicator.
See the baby. See the baby.
No, she's at my house.
Oh, she's fine.
I know she's gonna go stay with her.
She's the baby. She is a baby. She's the first. She did.
She can't get far. I was like, oh,
And then
before you
yeah,
go.
Yeah, she's cute.
Okay.
Yeah.
I was testing.
Yeah.
Within this field.
Yeah.
That's really good. If I could just come and say, oh, this is our friend.
And
Can
I
everyone
said,
spend that
she said,
Yeah. Wow. I feel well at ease. Because right now when I have my hands go.
she's really sweet.
Yeah.
She does really well.
Oh wait, she does dog grooming. Okay, that. Okay, now let's talk. When I say that, I'm like, like their operations and there's some like dog. No, that's more reasonable. Okay. Where does and does she do it out of the house or like she goes okay.
I can't
Yeah.
trust her. No.
How's it going? Really?
Well, we prayed about it, so hello.
So um this one like something what is it? What is that'll work too?
That's good. I love dogs.
Very nice. Dog you gotta get over it.
Yeah. It's 11. It's 11.
How's your business going?
Okay.
That salad is amazing.
You're on 16 now? You're on 16? Was it 17?
Can you hear me? All right. So we're going to get started in about 5 minutes. I just want to give everybody a little bit of a heads up. If you want more food, go ahead, have seconds. If you don't already know, the bathrooms are just right out in this hallway, and we'll shut these doors before we start. But about 5 more minutes.
You don't want to do this.
That's just stressful. I do miss my parents though. It's been the hardest part of this experience. It's way stressful. And it's just a lot of fun. Not so great. He just got an autism diagnosis, but I feel like we just had anxiety too. It feels like they just keep trying to take services away. Like he still doesn't actually know, even though he's going to middle school. So I'm kind of frustrated. January we're having like a IS meeting to see if they'll put autism as one of his criteria areas. And I guess that there's middle school has a lot of autism in it. I want him in like a small classroom with others. And they were like pushing for Roseman, but he sleeps. He's so far behind. But he's got like speech impairment. He's bigger, you know, and he's explosive. And he's so many things. And he's like stuck like a 6-year-old. And he's definitely not autistic. He moves this. It's like big hazard right here in the middle of the So I think it would be
I
good.
missed you last
But
night.
I have this matrix
Understood
where
that.
we check on private schools.
It
They
was
gave
me.
him like the lowest number. He's got like the behavior problems.
And I put him on my lap and he was just like on my shoulder. I was like, you didn't even make it to 6:30.
She's done it.
You can't do nothing at 900 hours with those kinds of issues.
Do you guys come to these regularly?
Pardon?
Do you come to
It's
these
frustrating.
regularly?
I've been trying to get them to call me before, but emailing and calling, but nobody's ever returned the call. You have to like go there. Okay. It's like maybe some, and then I was referring to her, so now it's not. So I can't believe that. But I knew they would
His kiddos.
we can still sign in, so I'm really like I'm gonna prefer that option from you guys still bus up students. That would also take care of the him trying to get to a bus stop on his own. He's been walking now from the bus stop. It's been going okay. He stopped at the super duck one day. He stole he like rocks into somebody's car and running over time, but overall it's going well. He makes it home. See you. She's still cooking, so is she not doing Christmas? Take her away. I told you the wrong thing. So here, sign in here and here. I told you the wrong thing. Hold on, we ain't done.
All right, everybody, how you doing? Welcome. I'm Kaylee, if you don't know, with Bridge of Life. We're so happy you guys are here. I have a few announcements, and then we're going to have All-Star, Chelsea and Mary are going to do some presentations for us. So a couple things I just want to make sure that you guys are all aware of. So first, we do still have space available for parent coaching through The Chosen. So if that's something you're interested in, you can reach out to me. I'll send this in an email so you have it after. We also have Giving Tuesday coming up the week after Thanksgiving. So on December 3rd, it's Giving Tuesday. That's a big fundraising day for us. So if you want to give, that's amazing. If you just want to share it, that's also great. If any donor that gives at least $50 gets a t-shirt that is exclusive to this Giving Tuesday. We have Ladies Night Out coming out on December 6th, and then Superhero 5K, so registrations are open for that, so I'll be sending information out for that as well. And that's all the announcements I have, so we're going to go ahead and get started, and I'm going to pass it over.
All right, hello. So thanks for having us. I see some faces that we know and have maybe worked with before, or just from the community. But my name is Chelsea Hernandez. I'm a licensed clinical social worker and also the clinical director at All-Star Children's Foundation.
And my name is Mary Bain Stevens. I'm a licensed mental health counselor, and I'm the family support clinician at All-Star Children's Foundation.
Yeah. We can go to the next slide if you would like. Our clicker's not working, so we're going to do some...
We'll be waving and
showing, hey,
throwing things.
Has everybody heard of All-Star? I know now we've been around for a little bit, but still here and there. So All-Star Children's Foundation kind of started actually back in 2016, 2017, but we kind of say our start date was 2020 because that's when our campus really actually opened. So we are a nonprofit pediatric mental health and research facility located here in Sarasota. We're off 17th Street in Lockwood Ridge. And when we first opened, we actually really were only focused on our foster care campus. So we have a foster care campus with 6 individually licensed foster homes, licensed through the Safe Children Coalition, where then our team, our clinical team is in the office building in the front and really kind of wrap around our families with all the services that they might need. So we have our family support clinician who works with our foster parents, our biological parents that are with the children. We have individual mental health clinicians, we have psychologists, we have an occupational therapist, speech and language pathologist, an educational advocate, and also case managers as well. And so the goal really is to try to understand what helps kids reach permanency, what supports are beneficial to foster parents, what supports are helpful for children in reducing trauma symptoms. So those are things kind of that campus is helping us understand and is part of some of the research that we're doing. Back in 22, was it 20? Yeah, 22, we opened outpatient services. So we also offer outpatient services to kind of our circuit. So that's Sarasota, Manatee, DeSoto circuit, offering kind of trauma-informed, evidence-based therapy services to children in out-of-home care. And then we also provide quite a bit of different trainings, some consultation, and then also trauma assessment and screening, as well as psychological testing. So we kind of do a myriad of different things on our campus, and I think you all should have received just kind of a brief handout that you can feel free to link with myself or Mary Bain if you have any specific questions. But really our mission at All Star is to help kind of foster change for our children and help them kind of alleviate any of their trauma symptoms. So we say we specialize in both trauma and child welfare and really try to kind of wrap around all of the systems that are involved with those children in treatment. So for today, our topic, one of the things that we've kind of seen as a challenge and worked with some of the parents here in our community is just trying to navigate services and trying to understand, like, when should I seek services for my child? What does that look like? What are the services out there? How do I know the services are appropriate to meet the needs of my children? And those can sometimes be really tricky and complicated. So our topic today is kind of going to focus on that. And we welcome really any questions, any feedback. This is a pretty small group, so hopefully you guys can feel comfortable just to raise your hand or ask us. We have quite a bit of experience between us, having kind of been in this child welfare realm and then also really specializing in working within the trauma field, specifically with children and adolescents. So happy to kind of pivot and talk about specific questions that you might have as well. But as we get going, one thing that's really important within just kind of our trauma-informed lens and how we function as an agency is beginning kind of trainings, meetings with kind of a ritual, an opening act to kind of get us going. And so in our agency, we oftentimes do like high-low buffalo. I don't know if you guys are familiar with that. Like a high is like a good thing, a low is something maybe not so great, and a buffalo is just something really weird and random. So we're gonna kind of change that a little bit to ask, in your experience with your children in this community, like what really awesome services have you had in our community? What's maybe not been the best experience, or what's something that was just really weird and strange that now you look back on and maybe just have to laugh at? So I don't know if anybody would feel comfortable sharing an experience just to kind of help open us up.
Anyone feeling brave? I'm sure most of you have experienced struggles in getting kids into services, so those would be, you know, your difficulties. Those are the kinds of things we want to talk about. Or services that worked really well, that you just got right in and things worked great. So we've heard them all, and so I don't think you can shock us with anything.
I don't know if this would qualify as services, but my son has been prescribed like a sensory swing and a trampoline and two other sensory things, and his insurance in order for it to cover that, he's got to go to the medical doctor. We've been battling since November of 2023. We still don't have it. We just put it on as Christmas gifts.
You know, and that's one of the biggest struggles, right? Is insurance and getting coverage for anything that you want to do. And sometimes you even have to be denied before then other funding cut steps in. So yeah, that's definitely, I would call that a low. Yeah. Yeah, I would call that a low.
Would you guys rather repeat anything that comes in for virtual audience when it's time talks?
Yes, repeat for the virtual audience because they can't hear the question.
Oh, okay. Oh, gotcha. Wasn't computing.
I think right now we're experiencing more of a high, because it seems like we've been hitting our head against the wall trying to get help, and just met a lot of, yeah, we'll put you on the list, and finally, it seems like in the last 2 months, we're getting some help. So I've been there where she's been, with all the kids, and finally it's
So a high would be after being on a waiting list forever,
yeah.
finally getting in and getting services. Yeah, that's always it took so long. I'm thankful it finally happened. Yeah. heard stories of, you finally get into services and things go great and it's wonderful. And I was actually talking to a client of mine, an adult client, who had bonded with her therapist, and then she went to see the therapist one day and the person had left. The internship was over, that person was gone, and didn't say anything to the client. The clients didn't know. So that's a hard thing, that people struggle with. It's hard enough to create a relationship and feel safe and comfortable in treatment, and then have them just disappear. Yes.
Our youngest is a traumatic brain injury from abuse, and we were told that we never really know what you'll get with brain injuries or when it will show up. And we have seen that over the last 10 years, and that's actually why we moved out to Illinois, because the district no supports for brain injured children. And we were like, I don't know how to parent this. And there was a time where it was so bad we really thought that we were going to have to do residential care, which is why we moved down here, because there's only a couple in the U.S. and one of them is in Clearwater. So that was our biggest struggle. There was no help for that. No help for brain injured children. There were plenty for brain injured adults, but none for children.
Yeah, that's a tough one. Finding services for brain injuries in children is, and that's such a sad one too, for it to be traumatic brain injury from abuse.
We'll tell you though, just changing environment, coming down here and finding a good medication regimen, thank God those are totally different. But it's always in the back of your mind, like, this is an uptick sometimes, so there's always like, okay, what are other resources if we need them?
Right, right. Thank you.
Any others before we move on? All right, I think we're good for the next slide. Okay, so tonight we're really kind of pulling some of this curriculum from the resource parenting curriculum. I know Ms. Renee has joined us in that training in the past. Has anybody else heard of the resource parenting curriculum?
AKA RPC.
Yeah, RPC. So the resource parenting curriculum is a parenting curriculum that was developed by the National Center for Traumatic Stress and CTSN. It's a really famous network. If you guys aren't familiar with it, they do a lot of research on trauma and evidence-based practices, and they developed this curriculum specifically for foster parents, adoptive parents, to be able to truly understand trauma and trauma-informed parenting strategies. And so we pulled some of this curriculum from that today, and then also kind of added a number of different evidence-based therapy modalities to give you guys some more information about those as well. So just to give you an understanding of our outline today, we're going to talk about maybe some of the signs and symptoms to be on the look for when looking for mental health services. You all are probably very well versed in this and are maybe better equipped than some others to knowing some of those signs and symptoms and what to look for, to know when to refer your child to therapy. Also talking a little bit about trauma screening and assessment. There was a new mandate that was passed July of 23 that requires every child coming into care having to receive a trauma screen within 21 days of shelter. And so that's kind of pivoted some of our treatment and what the state of Florida looks like in regards to ensuring kids get the right services from the get-go. We'll talk a little bit about trauma-informed therapies. Not all therapies are the same. And so it's really important to kind of understand what therapy your child is receiving. And then also, therapies are different and they meet different needs. And so giving you guys maybe a handful of ideas of specific therapeutic strategies so that you can be better versed in what those therapies are. And then being able to advocate for your children and asking maybe the right questions to ensure they're getting the right services. That can be a little tricky too in navigating and talking with the therapist and making sure that you're understanding what the therapist is saying and that you're involved in treatment. So we'll try to help give you some of that language as well. And then of course at the end we're open to other questions too. Pass it over to you.
Okay, I think just to kind of to dovetail with what Chelsea is saying, we want you today to leave this training maybe being better consumers for the sake of your children, in the services that they receive, more educated consumers, so that you know what to ask for, what to look for, because a lot of the time you're dealing with kids in foster care, and the services you get are pretty much, here's what it is, go do this. You know, there's not a lot of choice. But if you're educated on what to look for and how to ask those questions, you can then become more of an advocate for your child. And just a point of housekeeping, we have a sign-in sheet up at the front, also next to yours. If you did not sign up in that sign-up sheet, please do, because we do need that for grant purposes to have the number of people who come to our training. Yes, ma'am.
Sorry to interrupt. They're having a hard time hearing you on virtual.
Okay.
So if you could speak a little louder, and then also just feel free to repeat the question a little bit
Okay.
all the content.
Okay,
Thank you.
good. Okay, so sounds really loud to me, but that's probably what you need, right?
Yes.
Everybody else's hair is blasted back. So we want to talk about then to start with this is to, when do you seek help? You know, at what point is your child's behavior just a short-term thing? When is it not something to be worried about? When is it something you do need to worry about? And there's a little complication within our presentation that most of you, is everybody a foster parent? So are some people adoptive parents? Okay. From children in foster care? Okay. So when your children came to you, you would have known there was trauma just from the get-go. You know that with a child coming through foster care and having experienced those things. So it's kind of a given that that exists. But some of their behaviors, you're going to know right from the beginning, are difficult behaviors and things to be aware of. But then new things develop and other behaviors can start to show themselves. And that's, we want to talk about all of those things. And please feel free to interrupt, to ask questions if it's not real clear. But the first thing, your first signal of when to look for help for your child is when you're feeling overwhelmed by their behavior and their mood and their emotional symptoms. If you feel like, oh, I cannot manage this, then, you know, that's at that time to really start thinking about getting help for your child.
We can go to the next slide too.
Oh, yeah. Well, to seek help, that helps. Yeah, okay, so now that makes more sense, right? So when you're feeling overwhelmed is one of your first indicators, because you can kind of tolerate behaviors for a little while, and then it really is, it's been a month, it's been 2 months, and you start to feel like you can't manage it. Another thing to think about is in terms of the child, if your child displays reactions that interfere with school and home life. And I want to define that just a little bit. Like maybe everything, it's with that kind of thing, it's going to be a change in behavior maybe. Like they suddenly won't come to dinner at the table. Or they suddenly have separation anxiety when you take the child to school. Or they're all of a sudden fighting at home more with siblings or fighting in school. Those kinds of changes. So that's the kind of things that could happen within the time that the child, since they've been placed with you. But then other things they're going to bring to the mix right from the get-go in terms of coming into your home because they already have trauma. But I wanted to just kind of explain the reaction piece a little bit. Another thing, how many of you have had your child tell you their trauma story? Yeah. It tends to come out. Yeah, and so if a child is talking to you about traumatic experiences, then that is something that you want to get them some help for. You want to be able to listen, and you want to be able to hear it, and you don't want to tell them, oh, you can't talk to me, go talk to your therapist, but you also want to be aware that they might need more help than talking about it. If your child is committing acts of self-harm or talking about self-harm, has anybody experienced that? Yeah, yes. You know, that's a thing to be on the lookout for. That's a pretty serious issue. If they suddenly have trouble falling asleep, or they're waking up during the night, or having nightmares, Those are things to look at. There are ages and stages where night terrors and those kinds of things are pretty normal. But if it is something that is interfering with the quality of that child's life and your life, it's something then to maybe seek treatment for. Any questions about any of that? Please, yeah. Okay, the question was, what age is it normal to have struggles with sleep? Boy, that varies. My son did not sleep through the night until he was maybe 3, but then there are others that sleep through the night right at the beginning. Children with trauma are likely to have trouble sleeping, either falling asleep or waking up and not being able to go back to sleep, being afraid of being on their own. But do you have anything that you would...
I think sleep difficulties are super common, especially for any of our kids that have been in out-of-home care. And it's oftentimes a symptom of trauma, of depression, of a number of different challenges. And so I think one thing that could be really helpful is just tracking that sleep cycle, tracking when it's better, when it's maybe, not so great. And then obviously like routines and rituals, like trying to get that as clear as day for them to know exactly what's happening. But we work with teens that have trouble sleeping, whether it's like insomnia, just trouble going to sleep, not wanting to wake up at all. And, again, like Mary Bain had mentioned, throughout everything that we talk about, there's developmental expectations and norms, right? Like a high schooler is probably not going to really want to wake up. Like that's traditional across the board. And then there's pieces of that become more significant and start impacting our mental health. So I think a piece of it as well is, how is that child functioning throughout the day? Like, are they really struggling? Are they really tired? Are they falling asleep in school? Are they becoming irritable? We're always looking at the impact of functioning to also then to know how greatly is that harming them. And then trying to kind of put on our curiosity hat to try to understand where that's coming from. A lot of really scary things happen at night and in the dark. And so it's a really common trigger. Sleep time, bedtime is a really common trigger for a lot of our kids that have gone through any traumatic experience. And so to try to create a routine and a rhythm and a ritual so they know what to expect, it's the same every night. Sometimes kids, we had one kid I can think of that lived on our campus who wanted to put his bed in the middle of the room. That's where he felt safest. And so the parent was like, okay, like, I guess there's no harm in putting your bed in the middle of the room. And it helped him tremendously just to feel safe. For some reason, he didn't feel as safe up against the walls or the windows. But if he was in the middle of the room, he felt safer. So there's a piece of kind of that physical safety and that routine of just knowing what's going on. And then it's the psychological safety too. Like, what can I do to enhance this child's psychological feeling of being safe in this home? And sometimes that just takes repetition and experience, right? Like over time, okay, I feel like I can let my guard down a little bit. I feel more comfortable in this placement. But I think it's really awesome that you're aware of that and capturing that, because that's really important, just data to kind of store away for yourself to be like, okay, these sleep struggles seem like they're difficult for this child. And then kind of putting on that curiosity hat to see when it gets better, when it gets worse, to kind of track over time.
And that's perfect. And I think the thing to always remember with any of the symptoms and things that we're going to talk about is it affecting daily life in a negative way? Because lots of things can be little symptoms that you can live with, and the kid's still getting good grades in school, or eating well and having friends. You might have some little issues, but if it gets to the point where it's interfering with daily life, then that's when you want to make a move in terms of seeking treatment. So other things for our next slide, please. Yeah. So other times of when you want to seek help are your child. I don't know if this has happened to you. It's kind of a rare thing, but I talked with a young girl today or yesterday who asked for a therapist. If your child says to you they want to talk to somebody, that's really important. And it's easy to think, we want to always give grace and honor to those requests because you might think the child isn't struggling. And they might not have outward symptoms of anything that is a struggle, but they're asking to see a therapist. And so that's a time to seek help for that child. Another time would be when they talk repeatedly about a traumatic event. Has anybody experienced that with a child who just talks repeatedly? I've worked with children and families where that happens where the point of the parents just feel like, oh, I can't listen to this anymore. And it's becoming kind of traumatic for the parent. So if the child is kind of stuck on a bad time, a bad thing that happened, that's another time to seek treatment. Another one is the child feeling plagued by guilt or self-blame. I think a lot of children, when bad things happen to them, they say they caused it because probably their parents have said, it's your fault I hit you. It's your fault, that I locked you in the bedroom because you were a bad kid. And so you may see that come out in terms of just a child feeling very guilty and quick to take blame and quick to say that they're the ones that did it wrong, and when they really haven't. So that's another thing to look out for. And expressing feelings of helplessness and hopelessness. If you have a child who just says, I just can't do anything right, or a child that says, I'll never have a good life. And I've worked with kids like that, and you may have seen in your homes, children like that, where they just don't feel like they have a future. If you see a future focus in a child, that's a strength. If they have plans for their life and they want to be here and do things, that's a strength. If they don't, then that's something to really, first, you want to work on as parents to help them realize, yes, I'm worthy and can have a future and can do all the things I want to do. But if they can't get past those feelings, then you might want to seek help for that, because that can lead to other more difficult things. So severe and persistent reactions. Have any of you ever had a child who was just constantly having tantrums or constantly having problems in the home or constantly, you're nodding your head, yes? Yeah, and we know with your child that is a direct relationship to a traumatic event. So if a reaction becomes extreme or it just lasts for a long time and significantly interferes with daily life, that is a time to look for help. And if you see big changes, and I think we've already talked about that, suddenly they don't come to the dinner table. Or suddenly, how many of you know the signs of cutting? Suddenly they start wearing long sleeves and long pants, even when it's 90 degrees out. And you say, why don't you go put on short sleeve shirts? Oh, I don't want to. Any kind of big changes in behavior that raise your antenna a little bit, those are things to think about and maybe look for treatment for. Also, kids can regress to younger behaviors. If you have a child who, hopefully when their kids are in your home, they're not experiencing other traumas. So your child might come to your home at 10 and still wet the bed. So that's a regression in behavior. You would not have seen the change because they were wetting the bed when they came to you, but it's developmentally inappropriate. Or a child that starts sucking their thumb again, and they're 8 years old and they haven't sucked their thumb for 5 years. Physical symptoms can be suddenly like complaining of headaches, stomach aches, unexplained pains. And there's a book called The Body Keeps the Score about the body's, you're nodding your head, yeah, the body's memory of trauma. So you can even have pains in your body that have nothing to do with your current state, but relate to the trauma you might have experienced in the past. And your child
even
might do
in
that.
utero trauma.
Yeah,
I think that's really important too to think about.
Yeah, that's just that feels like such a bizarre thing to think even a child before they're born can experience trauma. And I think a lot of our kids in foster care, children in your home, problems don't start overnight in their families. So they have experienced long-term trauma. Um, let's talk about dissociation for a minute, or detachment. Have any of you ever seen a child just stare off into space and kind of not be there? Yeah. Or they seem disconnected from the family or the world. They just don't really react. They're not kind of in sync with everybody. That's a red flag, something to look for. Dissociation can mean they're just not, they've checked out of whatever's going on in the moment, and they might be revisiting that trauma that they've experienced. There might have been a trigger that makes them revisit it, or they might just be checking out, dissociating, so they don't have to experience emotions or reminders. So that's another thing. Like I've said already 100 times, just be aware of any notable changes. And as parents, you're going to be aware of that anyway. Be aware of anything that changes in your child's behavior, especially after a traumatic event. So that sounds really depressing, right? All these things to look for, all of these difficult behaviors, and so forth. But the more you're attuned to these things, the better able you will be to get help when the child needs it, rather than 3 years later.
I'll just jump in too, because I know we have a lot of adoptive families in here as well. I think one thing that we've seen historically in working with some adoptive families is adoption is a journey, and you all know that, right? And I think at different developmental stages, kids start to kind of conceptualize and understand maybe their adoption journey differently. And so we've worked with families that are, they have their children in out-of-home care, maybe in foster care, and then they transition into this pre-adoptive placement with the family, and we're doing work kind of the whole way along, and then they're adopted, and then we kind of successfully can say, like, okay, we think we're like, this is a good stopping point to end treatment, and then 3 or 4 years down the road, they might circle back. And that is very normal. And so I think that's something just to kind of be aware of, because I know not everybody is currently fostering, but might have adoptive children in your home, that some of these signs and symptoms that Mary Bain's talking about, they may shift over time as your child develops and becomes older. Adolescent years can be kind of tricky. They can be kind of tough to try to understand, like, who am I? Where do I belong? What would life be like if I was with my biological mom and dad? And those are all really normal questions to kind of explore. And so we've seen some really good work done with some families that, are able to kind of explore those questions together with their child, and trying to understand identity and trying to understand where their child belongs. So I think those are just some good points to be aware of as well, that, it doesn't necessarily mean if we adopt a child at a young age that, along the way there won't be questions, there won't be times to just kind of explore together, their sense of belonging.
Yeah, that's very true. I'm working with an adoptive family right now where the daughter was adopted. She came to their home as a foster child at 2 days old and never left. And by the time she was 2, she was adopted. And yet, she does have lingering effects of her experience before she came into the home. The mom used drugs, so there's in utero drug exposure. This girl knows no other family, but she will say to her parents, well, you're not my real parents, when she's mad at them, and so forth. And therapy has really helped her over the years, and so that can be that's another thing to think about for as a treatment need, is the adoption process and family identity. So I'm going to read you on the next slide, please. I'm going to read you a vignette, and I want you to just listen, and then we're going to go through it and try to see what you pick up about what this child needs. Okay, so 9-year-old Maya often comes home from school visibly upset, withdrawing to her room and refusing to talk about her day. Lately, she's been having recurring nightmares about being chased and has started wetting the bed again. At school, her teacher reports that Maya seems increasingly isolated and avoids group activities, often claiming a stomachache when asked to participate in class projects. While Maya appears outwardly well-behaved, her parents are concerned about the noticeable shift in her behavior and are considering seeking professional help to understand what might be causing her distress. So, lots of clues here. So let's go with observable changes in behavior. What do you see? Wetting the bed. Nightmares. Any other behaviors? Withdrawing to her room. That's good. Avoiding group activities. She's just telling everybody that she needs help, right? There are a lot of these. Avoiding group activities. So how about age-appropriate concerns? She's 9 years old. And so what's happening that is not age-appropriate for her? Wetting the bed. Yes. And that sometimes it's physical, and you always want to get that checked out medically first. But then it could point towards underlying anxiety and trauma. So that's one issue, another issue. What are the parents seeing with her?
She doesn't want to talk to them.
Yep, doesn't want to talk to them. Withdrawn. So they're seeing things that have changed, right? And that's what we've been talking about. They're seeing changes. And that is notable, that they're seeing changes. And so what do you think for the therapist, what if this were your child, what would you tell a therapist to look for and to work on with Miss Maya? And make it up, because there's no wrong answer. What might be triggers for her?
Something might be happening at school.
Precisely. Yeah, something might be happening at school because she won't talk about school anymore. So that's a thing to think about. I mean, we don't know. There may have been a recent life event that has caused some issues that she's reacting to. School dynamics, family dynamics. So I think the Maya vignette, the scenario, is a good one to kind of cap everything we've been talking about so far. So any questions about Maya, or any questions about one of your own children at this point that are starting to come up? Okay, let's go to the next slide. So this is the key takeaways. This is kind of a recap of what we've talked about so far. Early intervention is the best type of intervention. And that's why as parents, foster or adoptive, you want to just be aware of what your child is feeling as much as you can. No 17-year-old's going to tell you. But, aware and just be kind of curious, as Chelsea says. Be curious about what's going on with them. Consider age and stage, like the question you were asking about when are sleep problems more normal. Different sleep problems are normal at different times too, so night terrors are what, 6, 7, 8 years old. Wetting the bed is usually younger than that. So just being aware of ages and stages. Family involvement is crucial, and that's the thing we're going to talk about more as we move forward. But family involvement in treatment is critical for a child's success and for there to be any change in family dynamics and movement. And if you're starting to feel this stuff, feel these things are happening, who do you go to in your current lives? Who would you go to ask for help? Who would you take this issue to? Immediate family? Mm-hmm. Absolutely. Others in the same situation. So this group, school counselors, because I think every school has a counselor. That's a person to talk to. Pediatrician is another good one. So there are people out there where you can go to first to get your concerns met. Now, if you have foster children, the question's a little different. Then who do you go to? The first person you go to? Case manager. But once you've adopted, you're kind of on your own. And so that's where you have to have your own support network and go and know your church. Your church can be a good starting point when you're looking for services for your child. Let's see if I think that's it. We're going to pass it on to Chelsea in the next slide, please.
All right. So I mentioned this a little bit in our kind of agenda outline, but All Star has had the opportunity to be a part of this new process that has been rolled out where all of our children coming into out-of-home care have to be screened for trauma, which is really awesome and great. But then there's also a lot of complications that come with it too. And so one of the things we found was our community wasn't actually very familiar with what in the world a trauma screen was and what the difference between a trauma screen and assessment was. And so we've done some training on this topic in a number of different areas. But I think one thing that our state has done a good job of is trying to understand the importance of trauma. And I think our community has done a good job of trying to understand trauma. We have a lot of trauma champions trying to kind of help us understand how does trauma impact our children and what are maybe the best ways for us to go about being trauma-informed parents, trauma-informed clinicians, and a trauma-informed community. So I think there's like some positive progress, but we have a long way still to go. Trauma screening is super important because kids coming into care are screening at least 90% positive for having experienced trauma. And I think that number is really deceiving because if you go into out-of-home care, you've experienced trauma.
It's really 100%.
It should be 100%.
Yeah.
But just not everybody is necessarily identifying or feeling maybe ready to express some of those challenges. So we know our kids have experienced trauma in some way, shape, or form, especially if they're involved in the child welfare system. Research has shown us that when we don't address trauma, it results in some pretty significant negative outcomes. So we see behavioral challenges, we see mental health challenges, we see struggle with social skills, we see attachment difficulties. The list goes on and on and on, right? How many of you have had a child in your home that has had more than 2 diagnoses, mental health diagnoses? It is not uncommon that a child who's experienced trauma has up to 5, sometimes 6 different diagnoses. And oftentimes the result is actually trauma. The core of the symptoms we're seeing are a result of the trauma that they've experienced, but nobody's asked those questions. Nobody actually understands what that trauma is.
Is the trauma assessment the same as the CBHA?
Good question. I'm going to repeat
Yeah.
Is the trauma assessment the same as the CBHA, which is the Comprehensive Behavioral Health Assessment? That's a good question.
No.
Easy answer.
So the CBHA is really a social history. So if you're thinking of the CBHA, there is a clinician that gathers collateral documents from the person's life. So it might be the pediatrician, it might be previous records from hospitalizations, mental health providers. They do clinical interviews with caregivers, with biological parents, with the child. They'll do some behavioral observations. But at this point, the CBHA is not incorporating any type of assessment in the CBHA.
But to your point, they just recently have started doing the CANS and adding that to the CBHA, which is a brief screening. It's child, adult,
adult,
and adolescent. Child and adolescent needs and strengths. That's the CANS. And so now that we're doing these trauma assessments, we're getting the CBHAs with that CANS attached to it. And it does do a brief screening for trauma.
Yeah, the CBHA, as kind of your social history, it gives a lot of really good background and understanding as to what's happened, but it's not as clinically focused, and it's not specifically targeting trauma and conceptualizing how the trauma has impacted the child's behaviors. So I think that is a missing piece for sure. And there's always been some difficulties with the CBHA, so it's always kind of like we're trying to work with what we got, but also recognizing there's a lot of pieces that are missing that might be more helpful as a child enters care, and then we help connect that child to services. So I think with talking about having a number of different diagnoses, what often happens is a number of those diagnoses kind of overlap with one another. So what might look like ADHD, like inattentiveness, hyperactivity, trouble paying attention, those are actually also potentially symptoms of trauma. When we're looking at mood diagnoses, labile mood, so kind of those ups and those downs, suicidal thoughts, those are also pieces that could be contributed to trauma as well. So what gets really tricky if you don't recognize the trauma, all of a sudden a child now is diagnosed with a different diagnosis, and then that treatment trajectory actually is going to focus on that diagnosis and not the trauma.
And you're medicating for that diagnosis when you're really not dealing with the root issue, which is trauma, that if you dealt with the trauma, there would be no need for the other diagnosis and the medication to control behavior. Now, I'm not anti-medication at all, but unnecessary medication, because you're not dealing with the right issue, is a problem.
So just to kind of give some information as to why trauma screening can be helpful, right? It can really help direct treatment and get our kids in the right services from the get-go, which can be really, really life-changing for them. Ready for the next slide? Okay, so what's a trauma screen? Really, a trauma screen is a brief tool. So it typically can take around 15 minutes, maybe 20 minutes. It can be administered by a number of different people that would have training in that screening tool. So a clinician could administer it, but also a case manager. Also, a child protective investigator. A number of different people can administer this screening. And it does two different things. It says, what's happened to you? What are your traumatic events that have happened? And how are those traumatic events impacting you? Just kind of briefly. And then that gives us an idea of, what's going on and how the child is functioning. So I think some challenges with trauma screening. Right now, our community legislation was passed that we're using an ACEs screener. Is everybody familiar with the ACEs tool? It's a beautiful tool. It was not meant to be a trauma screener. It is not actually screening for symptomology.
Who has not heard of the ACEs? ACES.
ACEs. So the ACEs is a screening tool.
That's okay.
Yes, that's okay.
Yeah, better
The
to
ACEs
say.
is a screening tool. It was actually developed in the 90s, I want to say. And it was actually developed to identify medical outcomes for people who've experienced adverse life events.
For white Belgian males.
Yes. So it's for adults. It's not for children. So it's a very specific measure looking at health outcomes. So depending on there's 10 questions on this ACEs screener, depending on how many questions you answer, equates to a lower life frequency.
But it's still, even though how it was developed and who it was developed for, it's still a very useful tool.
Yes.
Yeah.
Yeah. So I think the challenge is how we're using it. It doesn't actually fit the need. It's not actually screening what it is supposed to be screening for our children, which can be really difficult. And so we're using this screener tool now for kind of screening our children for trauma symptoms. And unfortunately, maybe missing a large portion of our children because it's not actually capturing symptomology. I could have one thing happen to me and I could be functioning horribly, right? Whereas Mary Bain could have had 5 horrible things happen to her, and maybe she's functioning okay because she has these protective factors or strengths kind of supporting her. So that's one challenge. And so trauma screening, I think, we want to make sure we're using the right tools, and we're using tools that are screening for trauma. And then the other thing, just to kind of recognize as a barrier, screens are just this brief snapshot in time. So the reality is avoidance is a symptom of trauma. So a lot of times our kids might not be 100% honest with us on that screening tool. So screening needs to be periodic. We need to kind of come back to children 90 days, 180 days, just to kind of check in and see if that screener would result in different outcomes. Hopefully through some education and understanding of trauma, the child might become more comfortable in sharing about that. So if you have a positive screen on a trauma screener, what we'll also do is we want to screen for depression and suicidality. Depression is actually one of the highest co-occurring diagnoses that are in combination with trauma. And of course, that's probably pretty common, right? Because when really horrible things happen to you, it's bad. Like, it doesn't feel great. And so depression is a very common diagnosis that also is linked with trauma. We're also going to assess family strengths because, again, if somebody's struggling with trauma, but they are connected to a safe, secure, stable caregiver, they are involved in a community, they're participating in sports, they might have a better chance of working through some of these hardships because they're wrapped around with some of these supports. Whereas a child who was maybe just removed from their parents, is not involved in any type of extracurricular, has no community, is now feeling very isolated and alone, those outcomes might be very different for that child. So we want to look at those strengths too around the child. It's also important to give feedback. So if I'm screening one of your children and you're with me, I'm not going to just let you leave my office without giving you feedback on what just happened. And I think that happens often, right?
Yeah, that's one of the things in the beginning I was saying we want you to be more educated consumers. If you're working with a clinician who is not involving you and not providing feedback, that's something to think about. It's not probably the best route to take for your child.
So we want to be able to give you feedback and say, hey, this is what just popped on this screener. Like, this is what's maybe going on. These are some recommendations that we can look at moving forward, because that's really important for you guys to know as caregivers. And then we're going to refer you to a trauma assessment to really kind of dive in a little bit deeper to understand what that might look like. Okay, so we can go to the next slide. So I'm going to...
Can I ask a quick question?
Oh, yeah, go ahead.
So if you are informing the parents of basically some things that you discovered through your discussion with the child, are you now betraying the trust of that child? And they're not going to share with you as much anymore?
So
that's really
repeat
important.
The question.
Yes. So the question was, if you share with the parent what was going on in that screening result, is that going to betray the trust of the child? And that is really important work to do up front with the child. So what we do in our clinic is explain the process of trauma screening and what that looks like. So, you're going to come into my office, we're going to talk about some things that have been really challenging and hard, and then I'm going to try to understand how those hard things are impacting you. And then we're going to bring Miss Renee in, and Renee's going to try to understand a little bit too how you're doing so that we can come up with a game plan. So assessment and screening is a little different than therapy in the sense of, we want to be upfront and honest with them and kind of sharing with them, like, this is kind of this collaborative process. And it doesn't mean that me as a therapist has to tell you every horrible thing that the child told me. But the symptomology and how they're struggling, and this is an area that they're having a hard time in, is going to be really important for you as a caregiver to know then how to help them at home as well. But the key is being transparent and honest with the child about that process from the get-go. So the child doesn't think that everything I'm saying right here, nobody is going to know. It's kind of that process together. And then there's also confidentiality that as clinicians, we talk about often. And there are things as clinicians that we wouldn't share with caregivers because that is a sacred space for that child to be able to express. But there's themes and things together as a family unit and as a system that are going to be really important to that child's future, to their ability to kind of cope with some of these challenges. So my little tests for you, they all popped up at the same time. But I think one of the common myths that I've heard from working with different families and doing different presentations is if I ask somebody about trauma, it's going to lead to re-traumatization and they're not going to be able to handle it. And that's actually a myth. Research has shown that a child going through the assessment and trauma screening process doesn't actually experience more negative outcomes talking about and working through some of that trauma. It's kind of like the suicide question, like, don't ask about suicide because you're going to plant ideas in the person's head, which we've found is a myth as well, that that person might already be thinking about suicide or depression, and us asking about it is actually kind of helpful and alleviating. So the same is true actually with talking about trauma. I think the second thing as well is if our children screen negative on a screener, does that mean that trauma hasn't impacted them? No, not necessarily. Some of our kids are functioning better than others, but it doesn't necessarily mean that trauma has not impacted them in any way. So I think it's important to still kind of hold that idea and recognize, like, okay, at this stage of their life, like, they're doing okay. We have the skills in place to help them cope, but it doesn't mean maybe a few years from now things are different and things might be a little bit more challenging. So we just want to keep an eye on that as well. Trauma is kind of an ever-evolving process, and it's something that, you might be able to work through at a stage in your life, and then there's another stage that happens. And so it's kind of this ever-evolving, trying to figure out how to cope and work around some of the challenges that have happened in the past. Next slide, please. So trauma assessment really is kind of that next step. It's diving deeper. So trauma assessment is going to be a combination of a clinical interview, probably a standardized assessment measures, behavioral observations, and all of that is going to be kind of gathered together to conceptualize how this trauma has impacted this child in a number of different ways, right? So if my child is super aggressive, they're getting into fights, they have legal charges, my job as the clinician is to try to understand where that symptomology might be coming from and how it could be connected. So if I have a child who's coming from a home of domestic violence, who's seen his parents fighting, and now he himself is having aggression and violence, there could be a connection between those things, right? And so trying to understand how has his history in the past impacted the way that he's coping and functioning right now. And trauma assessments then too, they'll really dictate treatment for that child. They're going to come with recommendations for treatment, recommendations for caregivers, and those are going to be helpful to dictate the trajectory of the child's treatment and therapy. And these are going to be completed by typically licensed clinicians that have specific trauma training. So a number of clinicians in our area I know have that training, but there's going to be others who might not necessarily feel comfortable doing a trauma assessment. So that's just important to be able to kind of understand as you're talking with your clinician. I think as well, oh, yes, go ahead.
How do you handle if you don't know the trauma or they don't want to talk about it,
Mm-hmm.
or the parents or the caseworkers don't know the extent of it?
Mm-hmm.
It's very minimal, but you know there was something major. Like, how do you handle that?
Yeah, I think... Oh, I'm sorry. The question was, how do you deal with children who don't maybe verbalize all of their trauma and you don't necessarily know all of the things that have happened, but you know something's happened in the past? I think that's a great question. And I think the reality is, for so many of our kids, we're not going to know everything that's happened, especially our little ones who maybe have experienced trauma, pre-verbal, right, trauma, where they couldn't necessarily tell anybody what happened or what they've experienced. But we see these behaviors now in how they're acting, how they're communicating, how they're interacting with us, right? And so one thing that I would encourage, again, is that curiosity hat. So anytime a child is responding to a situation out of the norm, or it's a bigger response than what you anticipate, that's usually a clue to be like, okay, where did that come from? Like, what just triggered that behavior? I can give an example of one of the kiddos that I've worked with in the past was like consistently urinating on herself. And she was an older, middle school aged girl, so it was not normally developmental. And it was obviously very frustrating as the caregiver to help clean up this middle school child. And it felt like it was this like defiant, like, why is she continuing to pee on herself? Like, what in the world? But there's a reason behind the behavior, right? There's a purpose behind every single behavior. And so our job is to kind of get curious about what purpose does this behavior serve? How might this behavior have helped her in some way? Because behaviors are adaptive for our kids in some way, shape, or form, even if it's not adaptive for us all the time, right? Especially our kids who've gone through trauma. So this girl urinated on herself had actually had a history of sexual abuse. So if I urinate on myself and I'm gross and I'm dirty, nobody's going to come and want to touch me. And so that was nothing, like we didn't know that. It came out later in treatment, but it was a clue for us to recognize like, okay, something's going on. We want to just be ready. We want to, be safe and secure for them to be able to share with us. But we know this is out of the norm behavior. So I don't know if we always need to know everything that's happened, but we have to be kind of detectives and we have to be curious about behaviors. And if they don't fit the situation, then oftentimes it could be related to trauma, and trying to understand what is the purpose behind that behavior is really important.
And if I could, I think there's work to do even years before that in terms of how we create our family environment. As parents, we need to create the sort of family dynamic where talking about things and asking questions and having feelings and talking about feelings are okay. And that as parents, we all have very busy lives and everybody's doing 1,000 things at once, but being able to give the child time when they need to talk to you instead of finishing ironing the shirt, or just being able to establish that relationship and family commitment to making those things. It's making it possible for the child to feel safe to come to you with an issue, because that starts when they're 3. That starts when they're babies. In foster care, it starts when they first come into your home. But then that makes it possible then later, if something happens, they can bring it to you.
I think we're ready for the next slide.
Okay. So we've talked about assessment, we've talked about what all that is, and so now we're going to focus on what treatments are out there. What are the trauma-informed treatments that we can think about? And on this slide, think of these points as kind of your diagnostics for determining if the treatment your child is receiving is the right kind. So the basics of trauma-informed treatment are, one of the biggest things is that they're scientifically based. What that means is, you've heard the term evidence-based in talking about treatment modalities and so forth. That means there have been studies, more than one, that compare outcomes, to be sure that you get the same outcome across different studies to show that this treatment is effective. So it's been systematically studied, and data are there and have been put together to show that the treatment is effective. Your child's treatment should include a comprehensive trauma assessment, just the thing we've been talking about. If the therapist is not asking the child about trauma, or the adult about trauma, then they're missing half of the whole show. So that should be part of it. You should then get a treatment plan. When the assessment's been done and your child is starting into treatment, you should get a treatment plan that shows exactly what modality is going to be used, what they're going to do, and you should be part of that treatment plan. So that's another important piece of it. There should be, like I said, a comprehensive history done of the child and their life, so that when they're, so that they're getting the information that they need. So and I say there needs to be a treatment plan. You as parents need to be part of it, and you need to be part of treatment as well. Especially with some of the modalities that we're going to talk about, there's a huge parent involvement in effective evidence-based trauma treatment for kids. So next slide, please. Okay, so we're going to use a lot of letters and a lot of acronyms, and we'll get you through this. But the 3 main treatment modalities that we want to talk about are parent-child interaction therapy, which is called PCIT, trauma-focused cognitive behavioral therapy, which is TFCBT, and eye movement desensitization and reprocessing, that's EMDR. And we'll go through each of these and talk about them. There is a great website, and the website is the web address is right there too. NCTSN is the National Center for Traumatic Stress Network. Yes, and they really will tell there. It's a huge clearinghouse of information. So we'll go with that. So at All Star, these are three that we have certified providers who have been trained and know the specific modalities to provide these types of treatment.
So obviously our niche at All Star is trauma. And so all of these evidence-based practices would be trauma-focused and would be kind of the heart and soul of what we would provide at All Star. But this is not the comprehensive list of evidence-based therapies. There's a number of different evidence-based therapies, specifically fitting the need of your child. And the NCTSN website would have kind of a plethora of probably at least 100 evidence-based modalities and frameworks that you can kind of look off of. So next slide, we're ready for that. So parent-child interaction therapy. Is anybody familiar with PCIT in this room? Okay, a little bit. Yeah, so PCIT, it's a pretty intense therapy. We're lucky enough, Dr. Hoffman is a regional certified trainer for Florida, and so she has equipped our teams with PCIT training. But PCIT is a specific therapy for children, young children, so typically aged 2 to 6 years and 11 months, with pretty significant behavioral challenges. And PCIT is it's very unique in the sense the clinician coaches the caregivers on ways in which to interact with the child. So it's actually facilitated in a kind of double room space with a one-way mirror where the clinician has a microphone and the parent has a bug in their ear. We call it a bug in their ear, like a little mic or a little speaker. And the clinician is actually coaching the parent on how to respond to the child. And so it's really giving, I don't know if anybody's been to therapy and you're like, sounds really great in therapy, and then I go home and try it and it doesn't go the way it's supposed to go. So PCIT is really cool that it like really walks you through in real time how to respond to your child. PCIT has two specific phases. The first phase is all about attachment. It's all about creating warmth, security, trauma-informed interaction. So you have this safe base for the child to be able to really connect. And so the clinician coaches the caregiver on ways to focus on specifically praising the child's behavior, reflecting back what the child's saying, being able to kind of paraphrase, the child, pointing out what the child is doing. All of these behaviors have been shown to actually increase positive behavior in children. So once that level is kind of reached and there's this like security, this warmth in the relationship, the next phase then is kind of the behavioral management piece. And that piece specifically is helping the caregiver be able to address some of the most challenging behaviors and be aware of what they're actually doing to maybe amplify those behaviors. There's a lot of things that we do accidentally that actually put gasoline on the fire. And so that's where the clinician helps the parent to just recognize like, hey, we're not going to pay attention to that behavior, but the second they do this, we're going to praise that child. So the child starts to kind of learn and become conditioned to understanding that positive reinforcement. So PCIT, it's pretty intense, but it is one of the most effective modalities in helping children really kind of shift their behaviors and really enhance that parent-child relationship as well.
And when Chelsea says it's intense, I will say, because the treatment room is at the end of the hall and my office is at the other end of the hall. And kids, have you ever heard of extinction burst? When you're trying to change a behavior.
It gets really bad.
It gets really bad before it gets good. And so with PCIT, in the moment, the clinician and the parent, and it's the parent in the room with the child, they're doing something different and they're responding differently to these kids, and the kids know it. And so they're amping up their behavior to cause the parents to then revert back to their old behavior. And there can be fireworks, but there are huge payoffs in the end with this kind of treatment. Yes, sir.
This worked really fine for us until the second stage. Our child got very, very smart. they could not get him to act up at all.
Okay, so the comment was this worked very well until the second stage, because the child knew what to do to kind of get out of things. Was that what it was? Okay.
The question I would have was, did the clinician have the capacity to live with you in real life, like to go to your home and to be able to observe the behaviors at home? Okay. Yes, because that happens 100%. We have kids that have like stage fright, and we don't necessarily want to create situations that are like emotionally irritable for a child, right? So there's opportunities where clinicians go to you then as well. And the coaching looks a little different because then the clinician is with you in the home. But we want to be able to see those behaviors to then help respond to those behaviors, because that's really important. The first stage is beautiful. Like if every kid could have that first stage, like that is amazing. But we also want to be able to manage and change those behaviors. So that's really important too. I think the challenge is not all clinicians maybe feel like they're able to go into the home or don't have that capacity with the work that they do. I think one thing All-Star, and I know some other providers are just really aware of, is trying to figure out how to make the approach work and individualize that approach. And so going into the home and trying to sit with you in real life situations, like if dinner time's the worst time, then that clinician goes with you at dinner time just to kind of observe and be present for whatever that situation is like. Yeah. But you're not alone in that. That's definitely happened.
Clinician said, she said, we tried everything to set him off, and he goes, oh, mommy, thank you.
So you used your phase 1 skills, your CDI skills really well that time, yeah.
Okay, so now we're going to move on to the next slide and talk about trauma-focused cognitive behavioral therapy, or TFCBT. Special features of this therapy are that it's relatively short-term, very skills-based. It involves the family very much. The sessions are structured, and you go into the session telling the child and the parents, here's what we're doing today, here's what to expect, so on and so forth, so there aren't any surprises. And like we've said, it engages the entire family. TFCBT is a model that helps children, adolescents, caregivers deal with the effects of trauma, like all of these. Age range is like 3 to 18 years old. It can be at home, done at home, in the community, office, school, residential, and group care. The neat thing about TFCBT is that it has special applications for children in foster care, for children in adoptive homes, for children in residential care, for children with developmental disabilities. So it can really work with a big range of issues. And of course, it's dealing with the traumas that we've talked about: maltreatment, sexual and physical abuse, any type of trauma that a child has experienced. One of the big things that TFCBT does at the beginning is teach coping skills. And that's where the parent involvement is very important, because we're going to be teaching the child a coping skill to deal with their big behaviors and feelings that then the parent takes home and helps the child work on at home. There's also a lot of psychoeducation about the effects of trauma, what that all means. Children are not often given that kind of information, and to give it to them on their level is very helpful. They learn relaxation techniques, emotion identification, a lot of skills, a lot of skill building to start. It is evidence-based. The neat thing about TFCBT is that the thing that you're working toward as you're doing therapy is called a trauma narrative. And it can be done in 100 different ways. A child might want to write their story. They might want to do a picture. We've known of children who wrote songs about their story. And that goes along with, they learn all these coping skills first, and then they do their trauma narrative. And it's shown that it does reduce symptoms of post-traumatic stress disorder. So I can tell you a story about one child who, she was 7 years old, a quirky little girl in foster care, and she worked the hardest on her trauma narrative of any child I have ever seen work on this. It was page after page. We identified her traumas, and then she wrote a piece about each one of them. She rated them according to level of difficulty for her, and then she wrote a narrative about each one. That's what she chose. And she was a little girl who was 100% ambidextrous, so she would write halfway across the page with her left hand and then take the pencil and write the other half with her right hand, and just as fast as she could go. But then the goal then with this trauma narrative, the child gets it out there, and then you read it with the child a couple of times, because that repetition, each one, reduces the heaviness, the effect of revisiting those traumatic events. And then eventually, at the end, the child shares that narrative with their safe adult, a parent or whoever it might be. And so you also then, as a clinician, prepare the adult by reading them the narrative, having them know what the narrative contains before the child reads it to them, so that nobody's overwhelmed or surprised or anything like that. And so we've had some beautiful outcomes with kids sharing their trauma narratives and then being praised for that, being told how brave they are, and really then when you measure their level of distress, it's much reduced. So that's TFCBT.
All right. Next slide.
Okay. She's been sick for 3 days, and it's finally getting her.
I think I'm talking too much now. Okay. So EMDR, eye movement desensitization and reprocessing.
We can make this quick because we're getting close to time.
Yeah. Is anybody familiar with EMDR? Okay, EMDR is super cool. So this therapy modality in and of itself is obviously a trauma treatment as well. But the philosophy behind this treatment is that the brain can recover from a wound just like a cut could recover, right? So our body naturally, when we receive a cut on our arm, naturally wants to heal itself. The philosophy behind EMDR is the same is true with our brain. But if we don't process through that trauma adaptively and make sense of what happened to us and process through what happened to us, that wound starts to fester to the point where we start to learn other ways of coping with that difficult situation that might not always be as adaptive for us, right? Maybe more maladaptive behaviors to kind of offset the pain that this memory is causing us. So what EMDR does is through bilateral stimulation, so like back and forth across the midline, if anybody's familiar with any of that body work, using kind of this bilateral stimulation, taxing your working memory while also holding in mind the trauma, can actually reduce distress and distressing emotion to the point where you can then talk about the trauma without the emotionality behind it. So it's really, really cool stuff. So typically you'll see kind of these eye movements. So the eye movements would be kind of the typical EMDR process. But there's also tapping, there's also buzzers, there's also, noise, anything that is working both sides of the body. So go ahead.
No, I was just going to say the child that I work with likes a paintbrush stroked on each hand, back and forth. So there's a lot of different ways to do it.
So the goal of EMDR is really to kind of change the way memories are stored in our brain, which then results in eliminating or reducing problematic symptoms. All right, that's it for that one.
I think that's good. So let's go to the next slide, please. That's fine. So ineffective treatments, be on the lookout. This is part of your education as educated consumers. Anything that promises an instant cure, forget it. Not going to happen. Treatment that uses hypnosis or drugs to retrieve repressed memories. There's been a lot of controversy with those kinds of treatments where they did later found out that memories were inserted into the individuals, not for any nefarious reasons, but just by the act of hypnosis and that kind of thing. the brain becomes very suggestible, and so then all of a sudden the person perceived that they had been traumatized when maybe they weren't. Rebirthing, has anybody ever heard of that? Fortunately, it has gone by the wayside, where rebirthing would be where children or adults would have to have this, they would construct this tight, almost like the birth canal with pillows and blankets and they had to birth themselves again, and children died from suffocation, anything like so. Any kind of bizarre treatment, you just want to stay away from. It was not. Yes, and there was a center out west that was famous for that until that happened. So treatments that are offered by I hate to say anything negative about mental health providers who are working on licensure or and so forth. We all were there. We had to work on licensure, but trauma treatments are real specific, and it is better to work with someone who is licensed and certified in that particular modality that they are offering. And then, unlicensed people who aren't even mental health clinicians can offer trauma treatment, and anything that's kind of outside the medical mainstream. So there are things just to be cautious about. That's not to say some new thing might come up and be wonderful, but until it's been studied and vetted and is evidence-based, you just don't know. So those are things to be careful about.
All right, next slide. So this all sounds really great and wonderful, right? And like this perfect world, but we know we all live in the reality of our world and how challenging it can be to find the right services still. So at the same time, I think it's really important for caregivers to understand, like, what are the evidence-based practices available to me? What should I be looking for in a clinician? What questions should I be asking the clinician? And at the same time, trying to figure out ways to problem solve when we have to deal with the reality of our community and the services that we have available and the wait lists. And only so many providers can provide this treatment. And those are things that are challenging. So some things to just be ready for and some questions maybe to ask as you're working with providers in the future is understanding their readiness and their training in understanding trauma, right? We talked a little bit about misdiagnosis and understanding how our kids oftentimes have 5 or 6 different diagnoses and trauma might never have even been one of them. And so asking those questions like, do you have experience in working with trauma? What type of trauma measures do you administer? What modalities are you certified and trained in to be able to treat my child with these challenges? Those are maybe good, helpful starting points to ask if you're calling a provider, if you're talking to a clinician, to get an idea of their experience level. If goals of therapy are unclear, you are more than welcome to ask, what's the goal of therapy? What are some things that you're working on? What are the modalities? What section of this model are we on today? How can I be a part of treatment? I would like to be involved. Like, what's my role in session? Those are all questions that should be readily answered by a clinician, as you should be an active part of that therapy process.
And if you're trying to ask questions and you're being turned away, consider moving to some other place.
Mm-hmm. Inconsistent care, like Mary Bain's story, unfortunately, a lot of, many of you might have kids on Sunshine Health or on some type of Medicaid. And the challenge is the providers that serve those children are oftentimes students or oftentimes interns. And so you'll get providers that might have to transition, might have to change. There was one time I worked with a kid, I was his 17th therapist. And that's, I think, a big challenge for our kids, right? So inconsistent care can be a struggle. And I think it's fair to say, my child has had multiple therapists. Like, do you have the ability to work with him for the next 6 months, the next 9 months, however long treatment might be? To be able to get that consistency in your care is really important. The other thing to just be aware of is to clean out a wound, we sometimes have to be able to disinfect it. And so sometimes therapy can be hard. We're bringing up challenges in distressing emotion, and that doesn't mean we want to avoid it, right? We need to kind of dive into it and talk through it. So that's important too. And then lastly, I'll just add the challenge of having enough providers in our community is a real challenge. And so being able to kind of identify the right provider and then recognizing, okay, it's a 6-month wait list until I can get into that provider can be tricky too.
So just to bring it on home, let's go to the next slide, please, and we'll be finished. We have, with Chelsea, put together a list of resources in our community for mental health treatment. So please take that with you and hide it away somewhere. We added 3, and it'll be up here. I'll read it, but you can come up here and copy it if you want to. For ABA therapy, which is for autism, applied behavior analysis. We added Beyond the Spectrum. They have an ABA clinic. We added Hope Bridge Autism Therapy Center. And we added Virtus, Virtus Health. So there are some good services out there growing for ABA treatment. So,
and just know this isn't, again, comprehensive. These are just some providers that we work with and are familiar with, have either trained or trained alongside. So hopefully this is just a starting point for you to kind of add to your list of resources.
And I think we'll end it there. So thank you very much, everybody. If you have questions, we'll be here for a couple minutes.
All right. Well, thank you both so much. So just a couple ending announcements. You see the ornaments on the table? Go ahead and take them home, please. And yep, on the floor. You guys can have one too if you'd like. There's also leftovers from tonight in the back, and there's also some freezer meals there. So if you want to take either of those, go ahead. Please take everything. If you needed a certificate, they're on the silver table over here. Names are already on them. And then if you guys have any questions, you let me know. You all have my email address, and I did send a survey out, so please make sure you do that. That helps us with feedback for sure for all these events. And then if you have any questions, just let us know. Thank you.